Okay, thank you very much, everyone. People are coming in. I would just like to, before we get started, actually ask Suzanne Costello, the Chief Executive of the Institute for Public Health, the sponsors of this particular panel, to just come up to the stage, just to explain why this panel is taking place and the theme of this panel. So handing over to Suzanne Costello. Thank you.
Good afternoon, everyone. On behalf of IPH, we're delighted to be participating in the annual Centre for Cross-Border Studies conference again. It's a highlight of our year, so we're pleased to be here. And we're specifically supporting this panel discussion today on North-South cooperation on health and well-being. The Institute of Public Health was established in 1998, a few weeks prior to the signing of the Good Friday Agreement. But of course, the impetus and the energy for its formation was taking place several years prior to 1998. And that came from a recognition that the challenge of reducing health inequity and health inequalities on the island of Ireland is a shared one. The Institute was championed jointly by the Chief Medical Officers North and South and the Royal College of Physicians in Ireland. They persuaded both departments of health for the case for its creation and support, which continues to this day. So post the pandemic and post-Brexit, the case for cooperation in public health remains as strong as ever. But despite health being an area of cooperation within the agreement, unexplored potential remains. I'm delighted we have 4 very accomplished women to discuss the challenges and opportunities of North-South cooperation for health and well-being here today. Professor Deirdre Heenan, Dr. Nolan, and Joanne Vance, and our moderator, Marie-Louise Connolly. So over to you, Marie-Louise.
Well, good afternoon. What a fantastic event all day. Thanks to all of those who brought us together. I'm delighted to be part of it, and thanks for asking me to chair. So, for those who don't know, I'm Marie-Louise Connolly. I'm BBC News NI's health correspondent, and that means that I report on all things health and social affairs. And I've been doing so, feels like 100 years, but actually it's only been over 10 years. So we're going to hear from our panel, and then I really would like to keep the conversation going by hearing from you, the audience. So we'll leave about 15 minutes at the end, perhaps more, for you to ask questions. So as our panel say something that you want to ask them about, jot it down and you can ask the question towards the end. Most recently, something very peculiar, I think, has been happening. When talking to the various health professional bodies like the Royal Colleges, as I do almost on a daily basis, when they're talking about a service in Northern Ireland, and normally what they do is they will say, well, you know, when we compare it to the rest of the UK, when we compare it to the England, Scotland and Wales. But recently what's been creeping in, they've been adding what's happening in the Republic of Ireland. So they're saying England, Scotland and Wales and the Republic of Ireland. That's never really happened with me before, up until a few months ago. It actually happened yesterday when I was doing an interview with the Royal College of GPs, and afterwards I said, can I ask you why have you started to include the Republic of Ireland? And the answer, they said, I thought was interesting. Whenever you are working and living, whether it be business, health, the economy, in any sort of society, we look to the top. And at the moment, Northern Ireland doesn't have a top. There is no leadership. There is no guidance. But if we look not too far away, it's happening in the Republic of Ireland. There is leadership. There is guidance. There's sláinte care. There's stuff happening. We're losing health workers. We're soon going to be losing a lot more patients to the Republic. So that's why we've started to talk about the Republic of Ireland. I thought that was very interesting. So it is part of the conversation in my world to talk about all-island health or a all-Ireland health service. It's something that was whispered. It's something that while in practical terms it may have made sense, we did a big story. It was actually the DUP who encouraged paediatric cardiac surgery to happen a number of years ago, cross-border surgery. But very little has happened, I feel, since. And I would like to think I should know, because because I'm the health correspondent. But if I have to go and look for cross-border services, I really, really have to dig deep. We've got a fantastic panel. I don't know, I haven't got, usually I've got something to put my papers on, but I don't. So I'm going to have to juggle a little bit. As I said, the tone and the conversation about North-South, it is changing. We're here today to ignite and to develop that conversation, focusing on how we can improve systems, especially in public health, whether it be from Mallinhead to Belfast to Cork. Our distinguished panel, we have Deirdre Heenan, Professor of Social Policy at the Ulster University, Dr. Nolan, Assistant Professor of Social Work and Social Policy at Trinity College Dublin, and Joanne, Vance, Director of Community Development and Health Network. So what I'm going to ask you to do is make your pitch. You know what our theme is, what our title is. I'm going to start with you, Joanne. I'm going to give you each 3 minutes. I will sound a big bugle. I was going to say the boys over there in the sound desk, but they've gone. So just to keep it moving, you know what our theme is today. Make your pitch.
Okay, well look, I'm very well mannered, so I'll start off by thanking, need it up a wee bit. I'll start off by thanking the Centre for Cross-Border Studies and the Institute of Public Health for involving the community perspective in the subject today, which is it's North-South shared responses and challenges to health and well-being. And I suppose it's very important when we're talking about health and well-being that we move it beyond the health service. And director of CDHN has been going since 1994. We started just after the ceasefires. We are a Northern Irish regional organisation, but in 1994 we made the decision to base ourselves in Newry. It was intentional because what we like to do is address the social determinants of health. And anybody here this morning heard from Eileen around the issues that communities deal with on a day-to-day basis. They have a remarkable perspective on all the 80% of the issues that affect people's health and well-being. So that's why we were established. And of course, poverty and inequality and issues of discrimination and exclusion happen in all parts of this island. So it's timely that we're talking about health and well-being. It's also timely that we're talking about the role of community, because that is where it's at. There's actually tremendous policy alignment on public health and health improvement on the island of Ireland. It's internationally known that it has to be health in all policies, and that's what we're really excited and interested about. And I changed my career in 2000 and got into the field of health because I changed boundaries and I moved to Dublin, and I hadn't a clue about the system. I was totally ignorant of how systems work. You just know the system, you know, don't you? And what I can say is that the Institute of Public Health, I'd like to acknowledge the role that they've had in always bringing the North-South dimension together, having open conversations, deep conversations about the social determinants of health and inequality, and providing leadership, capacity and research.
There's a time difference between obviously Dublin and here, the 3 minutes, the 3 minute mark.
Yeah. As we used to say in Belfast, I'm in Belfast time, absolutely.
And off you go.
Thanks so much, Marie-Louise. Thank you to the Centre for Cross-Border Studies and also particularly the Institute of Public Health for inviting me here today. And one of the reasons I am here is on the basis of a small study that a number of us in the discipline of public health undertook during COVID-19. And it was very much driven by a popular narrative that was suggesting the Republic was doing far more, responding far more quickly in terms of COVID-19 than Northern Ireland. And so we set about testing that assumption in a very small study using some discourse analysis and minutes of meetings between the different CMOs. What we found ultimately is that there were tiny differences, and actually what existed was a lot of collaboration, dialogue, and coordination of policy changes between each. And when we spoke to, I happened to meet the Chief Scientific Officer and be on a panel with him, Professor Ian Young here.
He referred all the time to, because of course science is a process, and very often there isn't just one answer to a question around healthcare or how best to respond to a pathogen. So they were in dialogue all the time, north and south of the border, and agreeing how they would advise governments between Luconia, in the south, and then also in Young here in the north. And of course, behind the scenes, the chief medical officers on both sides were saying, yes, we're in dialogue regularly. We are actively ensuring that we are trying to coordinate. Of course, it wasn't perfect. And politicians took quite a divisive kind of position on it. But there was, and this is my lesson, I suppose, so I'm also here as someone who was an AIDS activist who led a community level response for HIV and sexual health. We always worked with partners in Northern Ireland. And that collaboration around HIV, sexual health, gay and lesbian rights went right back to the 1980s, including with dialogue between the Minister of Health at the time, Barry Desmond, and the Undersecretary for State, Richard Heenan, at the time.
Okay, I'm going to call 3 minutes.
Okay.
And Deirdre, you know what the view is like, where Mark is saying to you, 30 seconds, Deirdre. Well, I'm giving you 3 minutes.
Yes, well, I can reveal a secret. Mark Carruthers kicks me when the 3 minutes is up, so I will try and stick to the 3. What I will say is I'll bring my opening remarks around 3 points. The late, great John Hume said, you should always speak in 3 points. 2 are not enough, 3 is enough, 4 is too many. So really what I would like to say, yes, we are without a top in Northern Ireland. We are in a period of drift. We are in a period of uncertainty. But if we look at history and the history of health and cooperation, those are the very periods where we innovate, where we challenge norms, where we start to think about how to do things differently, how to do things better. So the first thing I would talk about in my 3 is the global pandemic. The global pandemic has changed how we think about health, how we deliver health, how health is provided, and who provides it. It really has shone a light on the role of communities. Think about those communities during the pandemic. The people going out visiting their neighbours, the role of the Orange Order, the role of the GAA, people manning phone lines, ensuring their neighbours weren't left isolated, but it really highlighted the role of the voluntary and community sector. And we began to talk about communities in terms of assets rather than the needs of communities. The second thing I have to mention, and you know I'm going to mention it, is Brexit. Brexit has changed the dynamics on this island. We are now talking about the constitutional question in a way that we weren't talking about it before, and that has of course brought health to the forefront of the policy agenda. Remember, in the UK, all opinion studies, when people in the UK are asked, what do you value most about being British? What do you think the answer is? It's not the monarchy, it's not the military, it's the National Health Service. That is why we're at the top of the policy agenda, and whilst we're at the top, we have to make hay when the sun shines and ensure that we do better. And thirdly then, the shared island. This is an opportunity for us to get things on the agenda, challenge the view of what healthcare should be priorities. Cancer is always up there for obvious reasons, but other issues really struggle to make it to the top. Mental health, for example. Why can't we tackle mental health on an all-island basis? For example, suicide. Young men, can't we have an all-island response to, does it make a difference if you're in Derry and Donegal, if you're suffering from poor mental health? So that's my third one, the shared island, and the opportunities that it brings and how we should shape those opportunities to get better services.
Well, let's take that issue of suicide and the 30-year-old who lives on both sides of the border, Deirdre. How could a cross-border programme work, save money, bring great ideas together? I was told during the week we have no money in Northern Ireland within the Public Health Agency. I know Nicola's here, perhaps, and hopefully you will correct me in this. There is no money for advertising anymore. The Republic does have money for billboards, for public health campaigns. Comes to suicide, what could we do on a cross-border operation that would help men living north and south?
Well, first of all, I would say that we have learned from the global pandemic, and some of what we thought we knew has been challenged. So, for example, we know that many young men are in crisis because of the economy, because of masculinity, because of toxic masculinity, expectations in society, etc., etc. I know from our students that there are problems in terms of mental health and, of course, the unwillingness to reach out and get services. Women tend to be more connected to health services because they have children.
And we talk.
And we talk. And the reality is we have a culture across this island where it says, you know, talking about mental health is a weakness. You're much better to hide it. It's going back to that old adage of whatever you say nothing. How do we challenge that?
So what do we do to deliver a programme that can serve North and South?
What I thought came out of the pandemic that was really interesting, we have very long waiting lists for listening, for therapies, for people to get help. We started with online counselling. We felt it wouldn't work, that many people rejected. Who liked the online counselling? Who embraced it? Young men. Because they didn't have to come into a room that you were sitting in and do the niceties. They didn't have to say, is she judging me? I wonder what she thinks of my clothes. It was online, their ability to talk about their problems, someone to respond, and this worked for them.
Joanne, I'm presuming that an online system is working both sides of the border. You know what it's like in grassroots and in communities. Is there an example, and let's keep with mental health, that is working but could work better if we were operating it on a cross-border basis?
I think that the role of digital and the fact that you can do...
Sorry, can you hear us at the back of the room? No, you need the mic.
Oh, forgetting.
It's a bit of a nuisance.
I'm thinking, Marie-Louise, about it. Mental health isn't my area of expertise, but I know from the member organisations are very focused on mental health prevention. But in general terms for service delivery, we know that online can be very good. During the pandemic, CDHN ran training programmes in health inequalities and community development. They were picked up by community development workers and health care workers on both sides of the border. So I think that because we go digital now, we can basically go everywhere. In terms of the quality, our members would say that, yes, embrace the digital, but you also need to build into your programmes times to be face-to-face as well.
Definitely.
You know, have the two, and I agree with Deirdre as well that you can attract people who are feeling excluded by using different methods of participation, and I think that is the role of the community health worker. It's the role of the health promotion officer, health improvement officers to know their community, know the evidence. I mean, the baseline for female suicide is actually going up. It starts at a low base, but it is going up. Male suicide is flatlining. So we have to be in touch with the evidence and pop that into your programmes. And then there's a few types of evidence. So you have your stats, very important. Talking to the communities themselves, finding out what will work, what won't work. Will the communities be involved in the delivery of this? Will they co-host it? From your point of view, I have to say it fills me with dread talking about digital and Zoom. One of the things that I enjoyed getting back to was when I can get to see the GP, but actually that face-to-face interaction again. From the studies that you have done, what is there out there on a practical basis that shows that we can work cross-border?
See, I mean, politics is the realm in which public health realises its objectives, because health is also, you know, it is a political choice. How we deliver health, how our access to health, whether or not the social determinants of health and how we live our lives is all ultimately decided by politicians. But when you have a political impasse, as there is now, in my experience, like for example, and I think HIV is a very good example of a similar scenario where a state cannot respond to a pandemic and a huge health crisis because of the narrative and in the Republic of Ireland at the time, of course, was the dominance of the Catholic Church and Catholic morality, which informed the policies of the state. So the reaction to that is that the grassroots level, statutory workers all came together to develop an all-island initiative for HIV and AIDS. You had gay activist groups working closely together. The cost of printing leaflets was prohibitively expensive in the south, So our colleagues in Northern Ireland printed HIV and sexual health information for colleagues in the Republic. We worked very closely together in terms of sharing information, sharing resources at that time. Simply, and with funding that was covertly issued. Because remember, while homosexuals had been decriminalised in Northern Ireland here in 1982, it was another decade before homosexual acts were decriminalised in the South. So very often our colleagues in the North were able to make statements on our behalf or put pressure on governments North and South to respond. When there is a political system that cannot act for whatever reason, and I worked in Eastern and Southern Africa quite a lot through the Irish Aid Programme and the Department of Foreign Affairs, covert policy is a way of getting things done. So very often you will have political systems and statutory actors who are willing to engage and to make things happen and to take risks. The framework, I would say, is already there in terms of good agreement.
I'm trying to get you all in every answer. Deirdre, what other examples have been operating over the past decade? The shared responses, we've heard about what has happened with AIDS, but from your point of view, what have the shared responses been like? Do you have to dig deep to find them, or are they happening behind the scenes and we just don't know?
Well, I did some work for the Shared Island and talked to 50 professionals in the area of health and social care across this island. And basically a number of findings came out of this. Yes, there are things happening, but they tend to be fragmented, piecemeal, and very much dependent on the individual who's leading that project, who cares passionately about it. Why is that? It's because there's an absence of strategic direction. So let me give you an example. This week we have the Brady report.
Hands up who's read the Brady report.
Oh, you don't know what you're missing.
Hands up who's read the executive summary.
Okay, so we have 80 pages.
So for those who don't know, what is the Brady report?
So this is looking at public health in the Republic of Ireland post-pandemic. What did we learn from COVID? What do we need to do in terms of community health? How can we harness the public support for public health? And how can we bring public health out of the shadows?
And it is brimming with ideas. But while I was going through it last night, I was wondering how many of these ideas will actually make it to the ground?
Well, I got my little search button on and looked for Northern Ireland, North, cross-border, and guess how many I found? None.
Zero. That's right.
So we are developing large-scale policies as though the other part of this island does not exist. So there is no strategic direction. How on earth can you talk about investing in communities and not talk about border communities, not talk about poverty that exists across this island? I don't know. And it is the very...
Why do you think that is the case? Why don't we feature our cross-border feature?
Because whose responsibility is it? Remember, health services in both parts of this island are under severe pressure. Financial pressure, but not just financial pressure, political pressure. So if there isn't a person named Marie-Louise who is responsible for that all-island approach, how do you think it's going to happen? It isn't going to happen. And the very fact that that person doesn't exist gives people the idea that this is something you can do in your spare time. This is something you might be interested in, but strategically, it is not important.
Okay,
and I think that is what we have got to lobby both governments to say, actually, in terms of common sense, this makes no sense. Because the other thing I would say, the one thing that came out of that study with consultants and people working in the system was, when I asked them about cooperation and collaboration, they look at you askance, as if there's something wrong with you, and say, collaboration is natural in healthcare. It's what we do. Everyone works together. Why on earth would you be asking us, do we want to collaborate? Of course we do, but we need to have the vehicle. We have the road, we have no vehicle. How are we going to make this happen? And as you rightly said at the outside, when I go to political conferences, people talk about cross-border collaboration in health, and of course they mention the Congenital Heart Network and the cancer services. They are 25 years old. It's time for a new tranche.
That we can develop that. How do we develop it, Joanne? How do we develop more services happening? And perhaps when we have Brady 2 report coming out next year, that, when we do a search engine, that we appear in double figures. Any ideas?
I hate to be flippant about this, but it's one document, it's one paper. Somebody's done a search on it. It doesn't look good on the north-south, but I think you have to look with your eyes. And you know, Deirdre's done the research with the 50 individuals and got a picture of it. And I know on the prevention side of things.
So are you saying on the ground it's a different picture?
No, what I'm saying is that we most definitely need a strategy that is joined up north and south. We definitely need resourcing for that strategy, which will be really, really important. And that strategy also really needs to take into account the different levels at which health planning and health design operates at, and with our population health approaches. You know, we talk about the community level, the local level, the area level, and then the system. And so my experience of developing initiatives and developing programs at the local level tells me that, you know, the way of going about it and the way that Anne has described it at the all-island level, it's the same way of doing it. It's just collaboration, it's bringing people together, it's having a shared understanding of what the problem is. It's looking at prioritising who have we left out and getting a programme of work, having improvements.
But is there, and this will all be, every story that we do at the moment, and it goes back to, well, we don't have a government in Northern Ireland, so therefore we can't get it over the line. And when are we going to stop saying that? So for people in the Republic of Ireland...
I think communities are saying that. I think communities are really tired and fed up of the lack of government. I mean, the cost of living crisis that people have endured.
But will people in the Republic want to do practical things with Northern Ireland if they're saying, well, they don't have
I'll give you a couple of examples of things that, you know, are taken over well, but that are very, very strategic. So, and hopefully maybe give you an idea of some of the challenges as well. So the one that's popping to mind at the moment, there's a budget crisis in the north. Our prevention has been sliced. I mean, it is totally, totally shocking, and we'll never rebalance this health system until we start investing in prevention. So we have an all-island social prescribing network. Colleagues in the north and south coming together on governance issues, raising awareness that they exist, a lovely map of Ireland, so anybody who is feeling isolated and alone can be referred by their GP or by another community group. But the community will look after the people in the best way they can, get them linked in with other things. It's a really well-proven evidence-based model, and it plays its role. And that network is existing. And what really concerns me, having a northern person working now in the north, having that perspective, is that in the south we have Sláinte Care. There is a programme of delivery there that will mainstream the like of the social prescribing projects. There'll be good wages for community health workers. In the north, the people who are providing that service have been told their funding is cut. Not in 6 months, not in 3 months, it's cut now.
Yeah.
So there's an inequality there.
So Deirdre, how do we balance these things? How do we get something up and running and working?
Well, I think first of all, the Department of Health here have to acknowledge the problems. And that for me is a starting point. So for example, workforce planning. The terms and conditions that we are asking the workforce here to work under are just not acceptable. It's the lowest paid region of the UK. And of course, as Joanne has said, our healthcare system is being hollowed out by the Republic of Ireland, where we're not talking about it. How on earth could you get a consultant to work in Newry when they can go 20 miles down the road and get almost twice the salary with better terms and conditions?
But without a government in place, that is unlikely to change in the near future in Northern Ireland.
But ask how many people know about this. Who's highlighting it? Why is it not top of the agenda? Why don't people understand what's happening when they look across the vacancies and say, I mean, do we really imagine that if Stormont's back up and running tomorrow, that these issues are going to be addressed? They are not going to be addressed, because we've had government stop-start for 25 years, and yet look where we've landed ourselves. So I think fundamentally we've got to, first of all, acknowledge what the issues are, and then, for example, workforce planning has got to be on an all-island basis, because you've got to be able to have specialisms.
But surely politics will get in the way of that plan.
Well, it has before, but other times people have managed to go around politics. So how do we manage cancer services? Because for the general public, regardless of your constitutional view, what is more important than health? and your family's health. And I was there as part of the discussions about the All-Ireland Congenital Heart Network. And of course people said, oh, no, you couldn't put it in Dublin. It wouldn't work in Dublin. We'd be better off flying people in Northern Ireland to Birmingham. To be fair, it was the DUP minister who said, absolute garbage. We are going to Dublin, and we went to Dublin. So sometimes we have to challenge our own stereotypes and say, can it be done? And I also think what we need to do is look at the projects that we can scale up, that we can capture people's imagination.
And I think we have done that, but it always comes back to we haven't the staff to make that procedure work. Look what has happened at the South West Acute Hospital, look what's happened at Daisy Hill, with the new Children's Hospital now in Dublin. I know there's talk behind the scenes of how perhaps Northern Ireland can use that because we don't have the staff. It makes sense that we would send children for certain services 100 miles away to use the facility in Dublin.
But I would like to go back to that. You know, yes, we have staffing problems in Enniskillen and in Newry, but no one's sitting around here thinking the city hospital is about to collapse or that oncology services are about to collapse. So why are they safe and secure? Because we have strength in numbers and because we know exactly what's happening in those centres. If we had been told 10 years ago, Daisy Hill is going to be the centre for orthopaedics, this is what's going to happen in Enniskillen, consultants would have gone there because that's what they would have wanted to do. The problem is, it looks like policy's been written on the back of a fag packet. Nobody actually knows what the long-term plan is for mental health services, for hospitals, for community development. And, you know, we are in the dark. Why on earth can our department not say, this is our plan, put it out for consultation, and so that people have trust and confidence in leadership?
Well, it's not what I think. And let's talk about the economic savings that could be made on such a small island.
I'm not an economist, sorry, Marie-Louise. I wouldn't be able to comment on that. But, I mean, it obviously
But there's bound to be.
Of course it does. I mean, health equity, for example, is a global policy priority. And there's a social inclusion unit in the south. There's also people
But there's
working
bound
on
to be.
health
It makes
here.
sense that there would be economic savings on
Absolutely.
such a small island.
Of course it does. I mean, I suppose if I can make just one small suggestion would be, for example, we know, and it's very much like Eilish and Brona said earlier this morning about the importance of bottom-up. When we are, you know, stuck in a conundrum and cannot change anything, that change, we know that societal change tends to come from the bottom up, and the politicians and the political system will row in when they've realised that the roof actually hasn't fallen in on everything. What we need in order for that community and voluntary sector and grassroots and communities to enable change, for healthcare consultants and nursing professions to be able to develop areas additional beyond, as Deirdre says, cardiac and cancer that have been around for so long, is to have funding models that allow blue sky thinking. And I think it was you said it yourself this morning, Eilish, you know, you get awarded a grant, you're delighted for 5 minutes till you see the burden of administration that comes with it, and you
filling
want to
in
send it back.
forms. Yeah.
And I think, you know, we've Shared Island Unit, I think, has an enormous role to play in opening up the arena for blue skies thinking, for allowing collaborators in academia, in the health services.
How easy is it to let academia in to help shape policy? Do politicians welcome that? Deirdre, and then I'll ask Joanne. You have experience of it. Are you encouraged to sit round the table? You've been there. Look at the things that a crowd of you came up with. You had a grand plan for the health service in Northern Ireland. How much of that actually has come about?
I think the politics of Northern Ireland are difficult.
And I don't want to get bogged down in the
but I would
politics
say
of Northern
this.
Ireland.
Health has devolved in Scotland. The academics in Scotland are in and out of the Parliament buildings as often as I'm in and out of our coffee shop. They are welcomed in. They're not deemed to be a threat. People will listen to them. Now, they may perfectly well disagree with them, but they are willing to listen. And the difference is there are evidence-based approaches. Our difficulty on this island, I think, is a real lack of robust evidence, and also the fact that we don't do data sharing very well. So when I go and ask for the data, it's either A, not available, or B, it's not compatible, or C, what do you want it for? And until we start saying, here's the data that shows this works, this doesn't. When Bengoa came here, the thing that he said that always struck with me, or stayed with me, is he said, in Spain we do this rapid review. So a project goes out, and Eileen, you love this, after 12 weeks they decide, this works, this doesn't. If it works, you get the money. If it doesn't, the money goes back. Here we have a pilot project that lasts for 3 years, regardless of whether it works or not. And in the end, the most ironic thing is, if it does work, the answer you get is, well, that's very good, but we've no money to
We're going to pull
it.
it, yes. And only this week we were trying to get figures on a story about cervical smears and what. Trying to get statistics in Northern Ireland is an absolute nightmare. I don't know what it's like in the Republic, but every health trust, and we do have 5, remember, they compile the statistics differently. So it's very difficult for me as a journalist to compare one trust with another. You'd think we were talking about different countries. You're talking about 10 miles difference down the road. The way we do things is differently. The way they record things are differently. The number of people they have staffing, for example, the Southern Health Trust, which is just depleted at the moment, staffing in that one health trust. So even I can't compare one health trust with another. How helpful is it, Anne, to compare and contrast in order to move forward?
We also encountered that huge difficulty in terms of looking at testing levels, morbidity, mortality in terms of COVID-19. We actually had to abandon that part of the project because we couldn't get data from the north or the south, or people were calculating morbidity differently and mortality, so or testing levels. So we had to abandon that part of the research project. It's hugely important in terms of understanding where we are, and Deirdre is so right. The data we have is just not robust enough. There are so many small studies undertaken with tiny grants on a qualitative level, with a small number of people saying, yes, we think, and citizens living on the border in the south and the north, of every colour and constituency saying, yes, we believe that health is a priority. The recent study there from UCD by Joanne McAvoy showed exactly the same thing. It makes sense, health matters to everybody. But ultimately, we face this constant problem.
Door slammed in face. I'm going to put this question to each of you and start down at the bottom. Has the pandemic encouraged or discouraged a shared response?
You've got all the hard questions today, don't you? I think that most definitely the pandemic has helped. I'm going to just put it out there.
Well, you had the memorandum of understanding that was put out there a couple of months into the pandemic, and we thought that was the green light. This is the way forward. That's the channel that's going to make it work. But Deirdre did it.
No, it didn't. I think the memorandum of understanding was an important point where we really felt now we are at an inflection point. We're going to see wholesale cooperation. The politics didn't allow that to happen, and that is unfortunate because the reality is we collaborated more around foot and mouth disease, around the cows, than we did around the people. That's the truth of the matter. So we've got to get over that, and we've got to be creative and use our imagination to see what would work. I will never forget Sir Ken Robinson, remember the late great educationalist who came to Northern Ireland, and he talked about blue skies thinking and creativity, and he said he went to school in Northern Ireland and the children were asked to draw something, and one child was sitting, with her hand over the drawing, and he said to her, "What are you drawing?" And she said, "Oh, I'm drawing God." And he said, "Well, that's very difficult because no one knows what God looks like." And she said, "Yeah, but they will in a minute." And so the point is, we have to be creative.
We have to be creative.
And we have to listen to people and say, well, actually, they have experience of this, and maybe they do know.
Let me go back to Joanne. I interrupted you earlier.
The reason why I'm hopeful that the pandemic experience will ultimately change things for a couple of reasons. It showed us the problem of health inequalities, the mortality rates, the preventable mortality, the absolute sheer unfairness of it all. So we've seen that now. We know what the social determinants of health looks like. We can't close that box. We've seen it. We know. Second thing I would say is that we have thought outside the box, and we have done things differently, which is a really, really good thing. The pandemic also, and Deirdre spoke about this, how local community organisations, GAA clubs, etc.
Hospitals changed overnight.
Showed
Yeah,
up
within-
and did what they had
Yeah.
to do through. They didn't think about budgets or resources or policy documents. They did it. They did it locally. And again, that won't go away anytime soon. We have to really connect back to the power of our local communities and the way that sometimes when you're hit with an emergency, you get things done.
Yeah.
We have a health crisis on this island. We have no resources going into prevention at all worth talking about. We need to double that. We will
But
never
that
address the
takes
waiting lists.
nerve, doesn't it? That takes someone up in the Department of Health and all the other departments to say, right, I'm not going to put all the money into the emergency departments, and this applies to the Republic as well. If you are going to prevent older people going into our emergency departments, it's not just a winter crisis now, it's a summer crisis too. The funding has to go into social care. So who's going to be the brave person to say, well, actually, I'm going to divert the funds from the EDs and put it into social care instead?
And I think
that's prevention.
I think that's why we've got a draft programme for government here. We talk about the health in all policies. We talk about really changing people's health conditions, being outside of the system. So that's really about having a look, ministers having a look across the budgets and saying, what are we duplicating here? What do we do? What are the benefits of us working together and sharing budgets? Local authorities have to do that across budgets. Community organisations have to do that when they're working in
And the problem is in Northern Ireland, there's no one being held to account at the moment. The pandemic, what did we learn from the pandemic that would encourage or discourage a shared response?
I think there's lots of reason to be encouraged by COVID-19, apart from the fact that we're all exhausted after it, and it probably is hard to mobilise communities. But certainly and it was a very small study, but again, engaging with an awful lot of people on both sides of the border since then, among colleagues, there was a lot of dialogue and cooperation within the confines of the political framework as it currently exists. So it's not perfect, but if we can continue that momentum and, very often, and recognise that it does come from relationships, it does come from the willingness of individuals to engage, and that everybody has a role in that. I mean, in the policy literature, for example, we talk about policy entrepreneurs as being the most important drivers of change. So that means at community level, at hospital level, at academic level, it's people who are willing to just drive forward, and including in our statutory services, people who just say, look, I don't care whether the system supports it, I'm going to try and make this work.
A little bit of blue sky thinking. Joanne, you're health minister for a day. I always love this question. You have an A4 sheet of paper, and you are looking at cross-border health, and you're looking at one or two areas where this is something that we can get up, and you two know I'm going to come to you next, so you've got a head start. An area that it's not complicated. Another thing, the type of demographic that we have in common, older people, right? Older people, both sides of the border, we know they're there, some of us feel it that we're there already. What one practical thing could happen if you were health minister that wouldn't perhaps require a lot of money, that would benefit older people? Joined up thinking. Any ideas what that might be? Is it travel? Is it...
I thought I had more power as health minister, now just to be focused in on the older people. I was going to knock all the heads together of the government.
No, tell you what, as health minister, what would you do for a day?
In terms of the older people, because that is a crisis on this island as well. It shouldn't be a crisis. We should be embracing older people, but because of the pressures in our health system, they're problematised. And there are a number of really good community-led examples working between community social care and the healthcare service that puts older people at the centre of it. That's happening in one region in Northern Ireland. So I would be setting up a task force to bring people together to look at all those good models of practice for older people, younger people, women experiencing mental health issues around maternity, just get all the good examples into a room and get some money injected into how you can scale this up. Let's learn from each other. I think
your health minister for a day, what would you do?
I think going back to that point about creativity is and allowing the space for creativity. I would absolutely, if I...
Would you let consultants round the table? Would you let medical consultants round the table to help shape your opinion?
I would let some of them. I wouldn't let it be consultant-led, I've worked in a school of medicine. There's a little bit of, that old joke, what's the difference between God and a consultant? God doesn't want to be a consultant. So I think it's a range of skills and knowledge and competence. And that shaping healthcare is more than just disease-led or consultant-led or medical-led responses. So it's engaging community actors, and that is ultimately what I would do, is make a fund available either through the Shared Island Youth that is untied to specific projects and allow people to apply for it who are working in areas other than. So I think this is the problem with a lot of funding at the moment. They're going for the quick wins, things that are already well established, to be able to point to them politically and say, look how effective this has been. Allow for other less popular areas, like, for example, health inequity. Allow for the social inclusion unit and other equity actors, community and voluntary organisations to come together and look at how their collective systems can work together to address equity on the island and across borders.
Deirdre Heenan, I know you've thought about this. Yes,
This keeps me up at night.
health minister for a day, but you're just not thinking about Northern Ireland, you're thinking north and south, and we want to see something. The journalist is going to be there with her camera within 2 weeks filming what you have created. What will I see?
Well, first of all, I would say the key thing is to get back public confidence and trust in health, because it is lost. Then I would say we need a 10-year strategic approach where we are honest with the public. We are honest about the state that we're in, but we're all working to get the same outcomes. So, for example, Manchester Health Trust, 1.9 million people. Northern Ireland, 6 health trusts. No more. 1 chief executive, 1 board holding that chief executive to account, money not duplicated. I don't care what you pay the chief executive, but there would be accountability, transparency, good governance, and we would have to accept that after 25 years and 7 major reports, the system that we have, and I'm not blaming individuals, simply doesn't work in terms of transformation. So we hand it over to a body, we give them the license to do it, but we also say to them that a key part of your work is the focus on prevention and early intervention, because what we have at the moment is a national illness service, not a national health service.
And where's the link between ourselves and the Republic?
So in an all-island approach, I would be saying, where are the economies of scale? How do we have specialisms? On an island this size, we can't have many specialisms. So where are the economies of scale? Transplant, for example. Couldn't we do this better on an all-island basis? Mental health promotion,
Obesity.
public health.
Obesity. Yeah.
Child health.
There's so much.
Falls.
Yeah. Okay. And breathe. Right, I'm nearly on my holidays. Right, questions, and I want lots of questions, and please don't look away. I love the way you all do this when I look across. Do we have a roving mic? That would be helpful. We do. So we're going to go to this table first, and then we're going to go to that table. So this table first, please, with the microphone. Say who you are, where you're from, and hit us with your question and who it's to.
Eileen Weir, Shankill Women's Centre. I coordinate Greater North Belfast Women's Network, which has a record amount of suicides in that area. Just something that comes across with me and the work that I do before I asked you the question is that if they were record the women who tried to take their own lives and wasn't successful, they would outnumber the young males. So, the statistics only count those who are successful. They're not looking at the whole problem of mental health. My question is, do you think that there's a sticking plaster being used on our mental health services and on our people who present themselves with mental health issues?
I think that the mental health service, as it is currently constructed is not fit for purpose, and I think that's fair on both sides of the border. And I think that we need a fundamental rethink about mental health. Everyone, I'd say if I said to everybody in this room, how are your stress levels today? How are you feeling? How are things going with you all? I'd say a fair few of us, if we were honest, would put up our hand and say, this is a crazy world we're living in at the moment, and we're all under pressure. And so we need to think of different ways of, coping with the anxieties and the stresses, and ask ourselves some really fundamental questions that go back to those structural inequalities that Anne talked about so well. There are, major changes happening in society that are placing people in very vulnerable positions, that are taking away their livelihoods, and the anxiety around climate change, all the pressing problems. These are structural issues, and if we don't try to look at those social and economic solutions to take the pressure off people in disadvantaged communities, well then, no amount of service delivery is going to fix the problem.
I shouldn't have taken the microphone away from you so soon, but are you talking to your counterpart in the Republic? Are they doing it any better than what we're doing here in the North?
Yes, I am talking to a counterpart in Dublin, Rolandstown would be one of the groups. Rolandstown would be one of the recent groups, but over the years I have worked from 2000 cross-border basis in a group in Tala, and we done a study visit in North City, Dublin, the suicide where the trees there, and a lot of methadone clinics is put up there.
Are they doing anything better that you can learn from?
And I think it's a sticking plaster. I think there's a lot of trauma. I think there's a lot of trauma in our communities, right across our communities, and they look at the mental health, but they don't look to see what's causing that mental health. So even, it's prescribed drugs. There's not, which is a common problem, north and south. Only we get ours free, and they have to pay for theirs down south. So there's a common ground with the areas that I work in and the areas within City Dublin down there. But I think what I'm finding, poverty has a big thing to do with the mental health.
Could I just say, Eileen, go back to saying we have no data. What we do know is that in Northern Ireland, we have a 25% higher rate of mental illness than in England. But we also know that in England, 13% of their total budget is spent on mental health. For us, it's 6%. So that tells you about the priority that we give to mental health. So I think there are issues. But the other thing we haven't mentioned is we've had 13 years of a Tory government, which has been neoliberalism and austerity. And of course that's had an enormous impact on the social determinants of mental health. And you can't separate the politics from mental health and wealth and prosperity and poverty.
Okay, can we run over time? I'm looking to the boss. We're over time. Can we go on for another little bit? Yes, of course we can. Right, I don't know who the boss is. I just sort of put that out there. Oh, you're Fuhrer today, I hear. Right, we're going to go. Can I ask the questions to be short and the answers to be even shorter? I prefer being out and about. This is much better. Off you go.
Really just to not have a focus on task force or studies, data. Let's just be data-driven in terms of the fact that we have, 6 million people on this island. Let's respond and put the treatments, create the centers of excellence, and decide that there needs to be an ED department per X thousands of people. And I don't care if it's at Daisy Hill or we resurrect Louth. Let's ignore the border and simply say these services will exist where the need exists statistically, and stop with the border nonsense. There are borders all over Europe where this does not present.
Have you got a job at the moment?
We are not.
Might you be free?
We are not terminally unique. Let's get over
Deirdre,
ourselves.
you've been
Here's
in
my
this
answer.
bear
You told
pit.
me to be short. I dream in data. Someday we will have the data that allows us to say, here is a population, and we are basing our service around population health, not random geographical decisions.
Case in point, we send young people who need treatment for eating disorder to England, or brace yourselves, America, where they don't get the family treatment that is at the root cause. Let's get over ourselves.
We have a woman in England at the moment, and it's costing something, so many millions per year, because we don't have a facility in Northern Ireland. She's 21, and we don't have a... Right, I'm going to move on.
Hi, my name's Susie Can. I'm out there with iCommunity. I sit between NICFA and the Wheel, the two umbrella organisations for the community and voluntary sector, trying to be a bit like the cross-border institutions that were talked about by our keynote earlier, except not funded in the way that... and it's actually to all three of the panel, because each of them talked about the awareness of how much the community and voluntary sector is innovating and responding. And in the Republic of Ireland, the Department of Communities actually published a principles and values for how to engage with us. And it came out of the basically a whole lot of problems with engaging with the health, the equivalent of health trusts in the Republic. And they realized that relationships had broken down and they couldn't talk to each other. So they went back to principles and values. And I'm just curious, do you think that something like that could help in Northern Ireland, that there's a principles and values about how health departments or how community health is engaging with the community sector that is coming up with ideas and innovation?
Joanne, you're nodding away there, curious.
No, absolutely. So, and very quickly, Marie-Louise, the Northern Ireland Integrated Care System put out a framework, and in that framework they put the community development principles and values in there. That work is progressing pretty slowly. Community and voluntary organisations are involved at the programme level, very much around how do you really fully understand what the role of the community and voluntary sector is. And remember, the community and voluntary sector is vast. That came out this morning as well. What the community and voluntary sector have to sort this problem, our health problems out, is a really fantastic understanding. That is actually their key selling point for these partnerships. It's not that they deliver services or they even can design good services. It's actually that they understand their communities really well. But when you look at the resourcing of communities, and when you look at the way community services are funded, it's all about the service delivery, it's all about the commissioning rule, it's all about conflict of interests. There's nothing in there about partnership working, and we need partnership working.
That's right. Okay. Lady, yes.
Yeah, just a quick point in response to the speaker over there. The Centre for Cross-Border Studies did a big study about, I think it was probably about 10 years ago, about cross-border health hospital planning. And it has just went nowhere, basically.
It's on that shelf with all the other reports.
And I think the other thing needs to be said is a shout out for cooperation and working together, who do a lot of good collaboration in healthcare across the border. All of it pretty much European funded, of course. And it's all pilot projects and things that don't get necessarily mainstreamed, and that's been an issue since they started.
And the funding's cut. Okay. You. Any more questions? Put your hand up. We'll get a mic to you.
Thank you so much. I'm Rosemary Steen, and I'm the chair of the Middletown Centre for Autism, which operates in Armagh. And I suppose just to give a little bit of hope and a question, myself and my vice chair, Sheila Darling, have been chairing the centre for the last 3 years. So the centre, is a model, a global model of how to support children and families with autism. So we do some things in Northern Ireland and the Republic of Ireland brilliantly well. And what we have to do more is lift those stories up and talk about them, why they work, how they work, and how we can impact on families and society. And I suppose, all of your experience, that's the... Hard work. Two people, myself and the vice chair, who really care. We care about the centre. We care about offering best-in-class governance. We've just appointed a new chief executive. We're dedicated to providing a standard of service to the child. So that when a child is lucky enough, unfortunately, that's what it comes down to. It is luck to a degree. To become a client of the Middletown Centre, they get whatever they need. And that transforms the lives of the children who receive that service. or we would have thousands of children waiting. But the issue for us is that we at least know what works. And I think part of the panel's discussion that I found really interesting is, you know, when you have actually then discovered that nugget of gold, it's how do you then cascade that out to the services and to the support around it. And I do think that women have a huge role to play in this in terms of leading that change, because I suppose it's brave to step up to do the training on governance and everything else, but we do actually have to go out there and do it and make the changes that we want to see in societal level and lead it. And I think just in terms of the panel, it's amazing to see all women as well leading on the panel on this discussion. If you were to give a gold star to another woman who's been involved in leading the change that you want to see in the health service, who would it be?
Right, but first of all, I'm really told that it's time to go home. But, for a couple of things, and that is great. The last time I just started my job and I was flying on the centre day doing a story. How, and I mean, we'll have to be quick. I'm going to be thrown out of here and not asked back. How do we build on that? How do we get that plan and make it work with another service or treatment? Deirdre, and it is 20 seconds.
Oh, first of all, my gold star is going to Professor Siobhan O'Neill, our mental health champion,
hear, hear.
who has talked the talk and walked the walk, and good for her.
Yeah, hear, hear.
Secondly, how do we do it? We listen to communities. We don't do health to people, we do health with communities. Because in the end, you can't go to Australia and get an anti-suicide program and expect it to work here. Health is cultural. There are cultural expectations, and the only way we know that is by listening. To date, we are very good at listening, but not hearing.
Yeah, my gold star will go to Dr. Connolly, who's leading an inclusion health model throughout Ireland and clinics that operate a low threshold in terms of care. For me, I think what you're doing is absolutely fantastic, and there are so many excellent examples of that. And I suppose the lesson from this and the name of this dialogue today, From the Ground Up, is ultimately replicating that over and over again. When that happens successfully, that's when the political system will come in and build a framework and support it. So I think it is, we have the power and the freedom to actually develop from the ground up, develop these excellent models of care, and then bring the political system in to support them.
Okay, Joanne.
It's very hard. There's so many gold stars to give out, but coming from the Community Development and Health Network, I'm going to give the gold star to our founder member, Ruth Sutherland, who worked really, really, really hard to influence policy to make sure that community development approaches and the social determinants of health were in there. And I'm delighted that it's a legacy that we're continuing today talking about it. So
Fantastic. I think we're all done, aren't we? Yeah, we're being thrown out. Okay, thank you very much. I could talk about this, as you can, I'm passionate about it. Perhaps next year we'll get an hour and a half or maybe even 2 hours. Deirdre, Anne and Joanne, thank you so much for your time, and thank you all.